Thank you very much, Carl, and good morning, good afternoon and good evening, everybody. It's an absolute pleasure to be with you today. Andrew and I are presenting on behalf of the Cochrane Qualitative and Implementation Methods Group today, for whom we are both co-conveners. I'm here in York in the North of England, and Andrew is in Sheffield. And York is also the home of the birthplace of Jon Snow, which, as Hugh was talking earlier, I thought was quite apt for today. So just a quick conflict of interest statement to say we've got no actual or potential conflicts of interest in relation to this presentation. So what we wanted to do for you today is to give you a quick introduction to the role of qualitative evidence synthesis in public health. We shorten that to QES, and qualitative evidence synthesis is the preferred term of a series of umbrella terms for systematic reviews of qualitative research used by the Cochrane Qualitative and Implementation Methods Group. We want to kind of outline what its purpose is, what it can offer to public health and policy, and to give you a couple of examples of how using and integrating a QES to inform systematic reviews of effectiveness in public health and what that can offer. And the two approaches that we're going to talk about is Sequential and Convergent. I'll talk about Sequential, and I'll hand over to Andrew to talk about Convergent. We'll give you a few tips and techniques. Ordinarily, we could run a whole module on this in a university and writing a whole handbook on it. So it's very much an overview, and hopefully we'll give you a flavour and tempt some of you into doing some qualitative evidence syntheses. And we'll also look at some future ways forward. So what is qualitative research? Just a quick recap for those of you who may be less familiar. Some of you will be very familiar with qualitative research from the polls that have happened before. But essentially, primary qualitative research is research that's generally interpretive, it's exploratory, it's explanatory. And what it does, it seeks to develop understanding and explanation for behaviours, for experiences and interactions of individuals, and more particularly and in relation to public health, the social context in which these behaviours can occur. And in relation to public health, that's clearly really important to understand why an intervention may or may not work, what situation it may work in, what may be barriers and what may be facilitators to helping an intervention in public health work. So why qualitative evidence synthesis? Well, it's a type of systematic review that brings together the findings from primary qualitative research in a systematic way. And the community today hopefully needs no convincing of the importance of evidence synthesis. I'm hopefully speaking to the converted here. And methods for conducting QES have really developed over the last 15, 20 years, a little bit behind those for effectiveness, but that was against a backdrop for increasing demand for decision makers, for evidence that goes really beyond the what works in healthcare and public health, and to draw on these broader contextual and both individual and system level factors that can help really get us to understand more aspects around the particular questions that we're asking. It can really help clarify interplay between the stakeholders around an intervention, the systems and the context. Thank you. So why qualitative evidence synthesis in public health? In general, any QES can help us understand what the values and preferences of end users are. And that's really quite important when we're designing interventions. It can really help us understand how acceptable something is and how feasible an intervention and health and social interventions can be when we're both planning them and when we're planning implementation as well, which is why we've got implementation in our methods group title. And also what kind of the impact is on both equity and equality might be of different interventions, and we've heard a little bit about that in the earlier talks as well. And some of the unintended consequences can start to be explored through qualitative evidence synthesis. And so in public health more specifically, we've got a few bullet points here as to what a QES can explore. Both health-related behaviours or experiences of illnesses, how and why something might work, how appropriate or acceptable it might be. And I've talked about barriers and facilitators already. And also it can help identify any gaps in primary qualitative research evidence. And what we particularly found is that there can be gaps about knowledge of acceptabilities of interventions in public health. So I talked about that we talk about two ways of achieving integration between a qualitative evidence synthesis and a systematic review of effectiveness. And the first way is a sequential design. And this is where one review happens after another. And actually the two reviews are independent prior to them being integrated. And the diagram here, I was just looking at it before thinking that makes something really quite simple look quite complex. That wasn't really the intention. But what you've got here is that the QL is qualitative and QT quantitative. So you've got either or qualitative or quantitative synthesis, you get the results. And then you move into the next review. So either the qualitative or the quantitative can happen first. Most commonly, what we see are systematic reviews of effectiveness, and then qualitative evidence syntheses happening afterwards in a sequential design. So just to give you one example of this, and this is quite an historic example about an effectiveness review, but kind of also gives that illustration of how long we've been doing this for. So there was a systematic review of effectiveness looking at the interventions for promoting smoking cessation during pregnancy that was undertaken by Lumley back in 2009. This review has now been split because there were so many interventions. This review has now been split into a number of different interventions. But at the time, one of the recommendations from this review was about the fact that the effectiveness review identified there was a gap around experiences of the target group, and particularly around perceptions of barriers and facilitators to change. And one of the recommendations and findings was that there was a need to gain greater insight into the experiences and vulnerabilities of women who continue to smoke in pregnancy, and therefore out of that develop sensitive and effective interventions which support women. So that was the precursor, so kind of the first review that then led to the second review, where we did a qualitative evidence synthesis which sought to provide evidence on how women's circumstances and experiences impacted on and influenced their smoking behaviour during pregnancy, including their attempts to quit. So this was a group of women who continued to smoke once discovering that they're pregnant. So a smaller number of women, because we know that pregnancy itself is kind of the greatest intervention to women stopping smoking, but actually the people who found this incredibly difficult to stop smoking during pregnancy. And we had a really good number of papers in this review. There's 29 papers reporting on 24 studies. I don't have time today to go into the findings, but what we got was kind of a real understanding of this trajectory through pregnancy. So being a smoker before somebody was pregnant, what the impact of pregnancy was on being a smoker, women's thoughts and feelings around being a pregnant smoker through pregnancy and their attempts to quit and trying to quit and then relapsing and continuing to smoke. And then finally looking at their smoking status at the point of delivery, which is where the data on smoking in pregnancy come from. That's whether women are still smoking at the point of delivery. And just to illustrate one really key finding that we found, one of the key findings of the effectiveness review that the interventions to support women to quit smoking tended to work through pregnancy, but then there was relapse as somebody gave birth and then went back to smoking. And they called that very much, it was a relapse. But actually what we discovered was that women intentionally, where they were able to give up smoking during pregnancy, intended to resume smoking once the baby was born. They gave up for the baby during pregnancy. So it's actually an intended resumption of smoking after they'd given birth, rather than a relapse of behaviour. So which kind of gave a really different interpretation on those findings. So it's a real kind of whistle stop through that, and I'll hand you over to Andrew now.
So yes, Kate's taken you through a sequential process through a review, and I'm now sorry, I can't advance the slides. Yeah, and so I'm talking to you about a convergent design. Sorry, I don't know what's right. Okay, a convergent design, and this can be done in three particular ways. So the center one is the one perhaps you're most familiar with, which is the epicenter model, which is where you conduct a quantitative and qualitative separately, and then you have a third synthesis that attempts to bring the two together. The first model is where you convert your quantitative data into qualitative, or your qualitative data into quantitative. And the third, which has application within Cochrane as well, would be the idea of doing the reviews separately, but bringing together the results and conclusions within a shared discussion area. So this is very much a current review. This is the return to work following COVID by the Cochrane Work Group. I was invited to join the qualitative evidence synthesis group. At the same time, the intervention review protocol was going through the process. You'll notice from the objectives here that the focus is very much on trying to understand people's experience in returning to work and what they needed as a result of their sort of work-related factors. You'll notice that within our group, we're not very keen on the idea of enablers and barriers because it tends to oversimplify complex systems. So we prefer factors, which then allows you to create more systemic models to interpret in different contexts. So some of the issues that have arisen through the protocol, and these link back nicely to Eva's introduction. Should the two reviews share a logic model or theoretical framework, or should they develop separately? Should the searches be taken together or separated using filters? Should we only use qualitative evidence of people who are actually undergoing an intervention to return to work, or should we be interested in people's experiences of returning to work? Should we only focus on return to work following COVID, or are there similar conditions conceptually that could be relevant? What type of study will we find? Will it be thin data or thick data? Because that will determine the type of synthesis, and we produce guidance to help in that selection. Issues around team leadership and membership for continuity and organizational knowledge and know-how, and whether the two reviews, although starting at the same time, would run to separate or coordinated timeframes. We've got tips and techniques, not quite as tentative as Eva's phrasing. So a plan for integration right from the very beginning, and our guidance paper shows different ways you can do this through the different review stages, through the different methods and tools being used, through communication and through common staff. Use the epoch review and protocol template for QES to help you to write both the review and the protocol. Consult the book that we're currently working on to be produced in a similar fashion to the Cochrane handbook. We've just embarked on writing that guidance now, with a view to it appearing next year. Involve Cochrane conveners and peer reviewers in the process of developing your QES, and above all, consider how the whole team is going to acquire skills. So for example, in our protocol planning meeting, I ran a short tutorial on use of formulated questions in qualitative research. And then looking forward, and this again maps nicely to Eva's presentation, perhaps we're going to see more genuinely integrated reviews rather than the sort of very simple sequential and convergent intervention and QES Cochrane reviews. I say simple, not in terms of the size of the task, but just in terms of the complexity of the design, the synthesis design. We're going to see an expanded use of theoretical frameworks and models at various stages of the review for various purposes. We're going to see the development, a further development of truly integrated methods that draw on both types of evidence simultaneously. And above all, we're going to see, and again, Eva hinted at this, we're going to see whole system review strategies, so that we think of how we're going to review intervention and implementation, not thinking of those as separate reviews, and quantitative plus qualitative. And just to conclude, we've been very prolific over the last few years in producing guidance, either with WHO or under the Cochrane umbrella, and here are a few starting points for you. Thank you for your attention.
Thank you, Kate and Andrew. We are just lagging behind a little bit, 6 minutes over time. There's just one short question. Joe, is there a short question for Andrew and Kate in the chat?
I think this has probably been addressed, but the question was, do we always conduct each review separately? And it's a question around publication, or in terms of publication, we publish it as separate review studies in a sequential review.
So I'll just quickly dip in that one, and then Kate maybe say something in the more general discussion. But just to say that there's so much added value of doing the reviews in an integrated way, whatever that integration may take. So as Kate said, you can get some value, and she illustrated that nicely, from doing them sequentially, using one to explain the other or to further explore. But really, if the teams have integration and the reviews and types of evidence have integration, you get so much more added value from that combined process.